Good evening, everyone, and welcome to this evening's session. My name is Grace Linehan, and I'm the Medical Liaison Officer at the Australian Prostate Centre. So I'd like to begin by acknowledging the Kulin Nation's traditional owners and custodians of the land on which we meet today, and I also pay my respects to their elders, past and present. So before we begin the education component of tonight's session, I'm going to briefly provide you with a brief overview of the services available at the Australian Prostate Centre. So we're a not-for-profit outpatient urology service located in North Melbourne. We specialise in prostate cancer while also offering a full suite of general urology, oncology and allied health services. And we also provide pelvic floor physiotherapy and a continence clinic for both men and women. So this multidisciplinary approach to patient care means that appointments can be made with minimum waiting times, and patients don't need to travel between different hospitals to access services. So we have patients who attend our clinic from across Victoria and who also come from interstate. And patients can come to APC at any stage of their cancer or condition and be connected to our multidisciplinary team, which is made up of leading urologists, medical oncologists, radiation oncologists, endocrinologists, psychologists, urology nurses, pelvic floor physiotherapists, and exercise physiologists located on site. And we also have a gym located on site at the clinic. And as a not-for-profit organisation, our out-of-pocket fees are kept to a minimum as we prioritise timely access to care. So we keep our wait lists at 1 to 3 weeks for routine referrals, and rapid access is available for urgent referrals, which are generally seen within 1 week. So thank you all for joining us for an update. Hi, can you please put yourselves on mute, please, if you're not already on mute? Thank you. I just want to cover some brief housekeeping before we begin. So the Q&A session will be moderated by Dr. Jane Crowe. So during the session, please type your question into the chat box, and we will address these both during the evening and at the end of the presentations as well by our speakers. And for your information, this event is being recorded, and an evaluation form will appear on your screen at the end of the session as you leave the webinar. So if you could just take 2 minutes to provide your feedback to us, please. So now to introduce today's speakers. Our first speaker, Dr. Praz Sivam, is a urological surgeon with expertise in general urology and a subspecialty focus in open and robotic surgery for urological cancers. He has both a fellowship of the Royal Australian College of Surgeons and membership of the Society of Urologic Oncology. As a senior lecturer at the University of Melbourne, he supervises research students through the university's MD-RP programme and also serves as urology training supervisor at Northern Health. After completing his postgraduate surgical training in Victoria, he completed a prestigious fellowship in urologic oncology at Memorial Sloan Kettering Cancer Centre in New York. Praz consults privately in Camberwell, Carlton North and Craigieburn, and he operates privately at Epworth, Richmond and Freemasons and at Cabrini Hospital in Malvern. And he also consults at the Australian Prostate Centre. So our second speaker this evening is Miss Georgia Roberts. Georgia is a physiotherapist with postgraduate qualifications in pelvic floor and continence. She's passionate about improving the quality of life of her patients and believes the best outcomes come from multidisciplinary patient-led care based on the latest evidence-based practice. Her experience covers both public, hospital and private practice across Melbourne and the Mornington Peninsula. Georgia is committed to continued professional development and supporting the industry of pelvic floor physiotherapists, and she tutors through the University of Melbourne Graduate Certificate of Physiotherapy in Pelvic Floor. And our moderator for this evening is Dr. Jane Crowe. Jane is a general practitioner who has also worked as a prostate cancer GP since 2011. Jane works in the androgen deprivation therapy and prostate cancer survivorship space, where she works as part of a multidisciplinary team, seeing men undergoing hormone therapy for prostate cancer to help educate, monitor, and manage their health holistically. So I'll hand over to Praz now, and our speakers tonight are going to talk to you on male lower urinary tract symptoms. Thank you, Praz.
Good evening, everyone. Thank you for this opportunity to talk to you about this topic. I'll just share my screen. So basically, again, I have no conflicts of interest, and there's just my basic details if you want to get in contact with me. Now, the learning outcomes from this talk will be focusing on initial assessment and investigations for men with lower urinary tract symptoms, and also to identify the red flags for referral to a urology service. And we'll be focusing on we'll start by talking about the etiology of lower urinary tract symptoms, how we assess them, conservative management, and then we're going to focus predominantly on benign prostatic hyperplasia, the most common source of male lower urinary tract symptoms, and look in the medical management and surgical management of this condition. I'll touch briefly on other causes during the assessment, but they are well and truly outside the scope of a talk of this length. So to start, causes of male lower urinary tract symptoms are broad, and we'll go into these in more detail, but the main things that bother patients the most are symptoms of related to bladder outlet obstruction, most commonly prostatic obstruction, but also produce nocturnal polyuria, producing too much urine at night, and overactive bladder, detrusor overactivity, which can be separate entities on their own. When we talk about lower urinary tract symptoms, there are basically two broad classes. There are the storage symptoms and the voiding symptoms. Storage symptoms include frequency, urgency, and nocturia. Frequency is basically the patient's perception that they're voiding more frequently during the day. There isn't a number that we prescribe to this. Urgency is defined as a sudden desire to void that the patient cannot defer, and it can lead to incontinence in some cases. And nocturia is simply getting up, waking at night to void, but can also include other phenomena such as nocturnal enuresis and overflow incontinence. Now, with voiding symptoms, they comprise flow symptoms, so weak stream, intermittency, something that's common with urethral stricture, straining, which can sometimes be seen with a bladder stone, for example, and also a sensation of incomplete emptying, where the patient reports needing to go and void, within a few minutes of thinking that they've completely emptied their bladder. I just wanted to spend a few minutes focusing on some of these symptoms in particular because of the broad range of possible causes. Now, with nocturia, so getting up at night to go to the toilet, there is nocturnal polyuria, which can be related to as patients get older, they produce less vasopressin at night. There's a reduced response of the collecting duct to ADH, and so they produce more urine than they otherwise would. There are medical conditions that can lead to this as well: diabetes, sleep apnea, congestive cardiac failure. Sleep apnea is particularly common as a cause of nocturia in overweight men who don't necessarily have other features that would line them up with BPH or other causes. And what's also very common is excessive nighttime fluid intake. People who drink, a full glass of water before going to bed and then get up at night and then keep drinking throughout the night to keep their mouth wet. And again, that's surprisingly common as well, and it's always worthwhile asking. Diminished bladder capacity is the second major cause, and these are related to bladder outlet obstruction, which is the focus of this talk, neurogenic bladder, or potentially even cancers of the bladder, prostate, urethra, again causing obstruction, medications, or even learned voiding dysfunction. And then you've got global polyuria from use of diuretics or diabetes. Urgency is another symptom that can have a range of causes: urinary tract infections, inflammatory causes from prior radiotherapy or chemotherapy, some chemotherapeutic agents. Malignancy itself can cause urgency or present as urgency. Several neurological conditions can have urgencies as a feature, including multiple sclerosis, Parkinson's disease, stroke. Bladder irritants, coffee, alcohol, diuretics, all important to ask in a history, and as well as constipation, irritable bowel, and idiopathic causes: overactive bladder, interstitial cystitis, which is a diagnosis of exclusion, and we won't really be talking about that today. And then looking at urinary retention, it's not always a man with an enlarged prostate. You can have anatomical causes of obstruction at multiple levels. You can have a narrow foreskin, stenosis of the urethral meatus. You can have a foreign body in the urethra. You can have calculi, clots, strictures, and then you have the prostate itself, which may not necessarily be enlarged, but there may be obstruction from a bladder neck contracture, inflammation, etc. There are various neurological causes that can cause retention. We commonly see urinary retention after major motor vehicle accidents, if there's been a spinal cord injury. It's also seen with sometimes after anesthesia. Since herniated discs, MS, diabetes, again, there are numerous drugs that can push a patient into retention, and often it's very clear on the history that the symptoms have started after commencing these medications. I commonly see them after starting antidepressants in a lot of patients, particularly SSRIs, and also medications that have antipsychotic features, but then also cold medications, narcotics, alcohol, constipation, we mentioned before. Now, in the history, we ask about the lower urinary tract symptoms, duration, severity, storage versus voiding, as we described before. Now, there are adjuncts to the history, which I'll go into in the next slide, and those include the IPSS score and the bladder diary. Ask about incontinence, whether it's urge incontinence or pure stress incontinence, whether they use pads, whether they're wetting the bed at night. So that's a sign of overflow incontinence and chronic outflow obstruction from chronic retention. Hematuria, whether they've ever had any urinary tract infections, episode of prostatitis, asking a sexual history in younger patients with outflow obstruction is also very useful because they may have developed a urethral stricture from a prior sexually transmitted infection or genitourinary trauma or other causes. Fluid intake, as mentioned before, urological history, particularly any instrumentation of the urethra, which can predispose to stricture formation, or any pelvic radiation. Family history is very important. I always ask about breast and ovarian cancer in addition to prostate cancer, as they can all be associated with increased risk of prostate cancer, as well as comorbidities to explain the causes mentioned before. Smoking, more as a risk factor for bladder cancer as a potential cause of symptoms, but also if you think that that's likely, you can ask about occupational exposures, and they're predominantly people who work in industries where they're exposed to hydrocarbons, aromatic amines, or certain chemicals. So spray painters, people who work in printing industries, hairdressers with exposure to dyes, people who work with fertilizers, people who work in aluminium smelting factories. So the IPSS is the International Prostate Symptom Score. Basically, we give these to patients when they present for the first time with BPH symptoms, and it's a good way for the patient before we see them to clarify in their own mind what their symptoms are, but also gives us a record that we can then ask down the track and compare whether any of our interventions have helped. Bladder diary is very useful, particularly in determining whether a patient has nocturia related to one of the many causes above, or nocturnal polyuria, in which case the production of urine overnight will be essentially equal to the production of urine during the day. It's also useful to determine what they're drinking and at what times, to counsel them on changing those behaviors, but also for the patient to realize for themselves, okay, they're drinking too late into the evening. On examination, basic examination, I always also check the external genitalia for obvious phimosis or meatal stenosis, penile malignancies. It's embarrassing when you work in the public sector and a patient appears on your operating list for a TERP, for example, and they've got this phimosis, which may be the cause of all their problems. A digital rectal examination is important if you are considering prostate cancer as a possible cause, so high PSA and appropriate age group. And a screening lower limb neurological examination is also very useful in the patient who you're not quite sure whether there may be a neurogenic cause. Now, investigations, check the kidney function, check the urine for blood or infection, check their PSA. If they're above 50 or between 40 and 50, if they've got a strong family history. I always like to get a renal tract ultrasound. It'll tell me the prostate volume, what their post-void residual volume is, and it can also show any complications of BPH that would mandate surgery, such as a bladder stone or very, very high bladder volumes with pressure effects causing hydronephrosis, which would lead to renal failure. In the clinic, we also do avoiding flow rate. This is useful prior to surgical procedures, but the accuracy does vary from place to place. And depending on how much the patients had to drink and how much they avoided. If they've only had a small amount when they attempt to avoid, then it loses its accuracy. I find it very useful, for example, in patients who may have a urethral stricture. They have a very particular flow pattern compared to patients who simply have BPH, who have a very similar flow pattern to unobstructed patients, except it's just longer and slower. I perform a cystoscopy in only those patients where there's any history of hematuria or prior history of bladder cancer. If I think there's a urethral stricture and I want to exclude it. And also, if you do a cystoscopy and there's bladder trabeculation or sacculation, that reinforces a diagnosis of outlet obstruction and makes you comfortable to go ahead with your management options. Urodynamics. Now, this picture shows a traditional urodynamics setup. I only offer that in patients who have, in men with lower urinary tract symptoms who have either a suspicion of some sort of neurologic dysfunction. So, example, all Parkinson's disease patients, I wouldn't operate on unless they'd had urodynamics first to confirm obstruction, or in patients who've had treatment but they have persistent symptoms. It is it's quite an invasive test and involves catheters both in the bladder and the rectum to measure pressure across the bladder wall. And there are various maneuvers where the bladder is filled and then the patient then voids and empties. And so it's somewhat invasive, can take up to half an hour, not as quick as a cystoscopy under local anesthetic. So I reserve that for those particular situations. Just to give you an idea of what we may find at cystoscopy, the first picture here shows a urethral stricture where the lumen of the urethra has scarred down completely, and you can see a narrow tunnel beyond that, and this would need to be opened up to relieve voiding issues. There's no medication that can fix this. This is a scar. It's a fixed obstruction. It needs to be surgically corrected. The second picture here shows evidence of bladder wall trabeculation. So the bladder is a muscle. And like any muscle, if you overwork it, it will hypertrophy. And so what you can see here are thickened bands and the beginning of sacculation in between those bands as a result of long-term outflow obstruction. The third picture is what we see of a collection of bladder stones in a patient who's been obstructed for a long time. These stones are typically round and form as a result of stasis and not emptying the bladder, high post-void residual volumes for a long time. You can treat the stones, but they will come back in this patient or patients who are prone to them if you don't treat the outlet obstruction as well. And finally, this is what we see on endoscopy if there is a degree of obstruction and occlusive lateral lobes, although we wouldn't make a decision on surgery, for example, based purely on the appearance of cystoscopy. We take into account all the other factors as well.
Praz,
now,
the urethral stricture,
yes.
how often does that recur?
So with strictures, strictures will recur because, like any scar, as it heals, it'll contract. So with all of my patients who have their first urethral stricture, I get them to learn intermittent self-catheterization, and I get them to do that daily for several weeks after the stricture's dilated. Because basically what you're doing is you're stenting that open while it's healing. So while it's healing and the new scar is forming, it's healing in an open position. Patients who don't perform intermittent self-catheterization or any form of catheterization for a period of time after this, after having a stricture treated, most often will recur. And when it does recur, it tends to be denser and longer. And the more you keep repeating dilatations, the harder it is to stabilize. And eventually these patients end up requiring urethroplasties, which is a major operation that can involve skin grafts from inside the cheek to produce healthy skin to then create a patent urethra. So it can get quite involved, and it's best to avoid that. So with all of my patients anyway, I always start them on ISC. And the duration of IC varies from patient to patient. And usually I try to wean them off within a few months, but I have some patients who need to keep going with it because they find themselves prone to developing new symptoms.
Thank you.
Now, with so the first point that I want to make was that how big the prostate is on the ultrasound does not necessarily correlate with their symptoms. So you can have patients with very, very large prostates that have no symptoms whatsoever, and you can have patients with very small prostates who have very severe symptoms. So be aware of that. And also the degree of obstruction does not necessarily correlate with the severity of symptoms. So you can have men with very significant objective measures of obstruction, for example, a very high post-void residual volume, hypernephrosis on ultrasound, but they may have very few symptoms. And a lot of the time, these patients creep up on you. You're monitoring their BPH and, without any medication because they've got no symptoms. And then you get a call from the GP saying, oh, I'm sending him in, he's in renal failure, and you do an ultrasound and he's got bilateral hydronephrosis. So again, something to be aware of. And finally, at least for this section, you can have BPH and you can have prostate cancer in the same patient. They coexist. So if you have a man with a large prostate who has prostate cancer and he's symptomatic because of his large prostate, the benign growth, the benign growth of his prostate, not because of the cancer. If you have a man with a small prostate and a very large cancer, then you can have symptoms, but you shouldn't use symptoms as a measure of risk of having a prostate cancer diagnosis. That's what we rely on the PSA for, because usually if a patient has symptoms related to cancer, then it's kind of advanced by that stage, and our options for treatment are limited. So starting off,
I've got a question. I'm not sure if you want to answer it now, but I'll ask it. Wasfi's asking, what is your approach for a patient, 62-year-old lady? The renal ultrasound and CT-IVP showed bilateral hydronephrosis, congenital extrarenal pelvic in the right side, and renal pelvic stenosis in the left side, normal UNDs, and the appearance has been stable for the last 3 years.
I think that's a very specific question that would require me to actually assess the patient and take a history, and I wouldn't give an answer based on that. But if the patient's asymptomatic and they've got normal renal function, then potentially you do nothing. But the question is whether there is a malignancy as the cause of those features. Again, this is a woman, so we are focusing on male LUTs in this presentation. But look, I'd be happy to have a look at that case at a later stage and answer that question specifically, but I would need more information than that snippet.
So thank you. So maybe Wasfi can get in contact with you by email or something after. Thank you.
Definitely. So in terms of conservative management of lower urinary tract symptoms, watchful waiting is a reasonable option for men who have lower urinary tract symptoms that are not bothering them. But predictors of failure are, as I mentioned earlier, patients with high post-void residual volumes, or if they have symptoms that are increasing over time. Conservative management is just encompasses all the things that we mentioned from the history, including reduction of fluid intake at specific times, moderation of caffeine and alcohol, and that includes teas, because teas do contain caffeine, which is a bladder irritant. A lot of men complain of post-micturition dribble, which is just a teeny soiling of their underpants after going to the toilet. And a lot of the time, it's not necessarily related to BPH or actual obstruction, but simply the anatomy of the urethra and a simple maneuver such as putting pressure behind the scrotum to straighten out the urethra eliminates the bend in the bulbar urethra that causes where urine can pool until the patient starts walking around, moving around. Bladder retraining is something that Georgia will talk about in more detail with regard to physiotherapy, and the other benefit of physiotherapy being that you can help reinforce all of these other behavioral modifications to maintain symptom control. Also, consider the role of various medications in the patient's presentation and whether you need to get in contact with, for example, the patient's psychiatrist to consider changing their dose of antidepressants or antipsychotics. Treating constipation, it's surprising how well that is enough to settle down a lot of symptoms, in particular urgency, once the bowels become regular. Now, to focus on BPH, I'm not going to get too much into anatomy. I think George is going to talk about that shortly. But with regard to BPH itself, the main cause is related to an increase in the prostate stroma as a result of getting older, basically, and as well as an increase in the number of alpha-1 receptors in the stroma. So this physically obstructs the lumen of the prostatic urethra, but also increases the tone of the bladder neck and the stroma as well. And in this diagram, you can see the transition zone highlighted as the dark purple area. This is the area that increases in volume in BPH and leads to obstruction. So complications of having an enlarged prostate include symptoms that get worse and worse, developing hematuria that can be related simply to BPH rather than anything more sinister, developing recurrent urinary tract infections, developing stones in the bladder, going into retention, and the worst case scenario is when the bladder completely decompensates, the patient develops high pressure renal failure. So after your initial evaluation, you make a decision as to whether or not the patient has any strong indications for surgery, and that's mentioned in the illustrated in the red circle there: infection, retention, stones, bleeding, failure. If they don't have any of those strong indications, if they have mild symptoms, you can potentially observe. If they have moderate to severe symptoms, then the options are either proceeding to medical therapy and then or proceeding directly to surgery. And there's also the option of further tests, as mentioned above, if the diagnosis isn't initially clear. Now, going through all of the different medications, I put up some pictures, and then I was told that I'm not allowed to have drug names. So Grace was kind enough to black them all out. But alpha blockers are the mainstay for BPH treatment. They include tamsulosin and silodosin. They work by inhibiting the effect of noradrenaline on smooth muscle cells in the prostate, and then thereby reduce the prostate tone, bladder outlet obstruction. The effects can take a few weeks to fully develop, but most patients notice something within a few days. Can reduce the IPSS and the Qmax. Qmax is the maximum flow rate as measured during urodynamics and flow testing. So it can increase that by up to 30%, reduce the symptom score by up to 40%. Regardless of the prostate size or the patient's age, they can reduce both storage and voiding symptoms, but they do not reduce the risk of developing acute urinary retention or the need for surgery. But if someone does develop retention, you put them on alpha blockers that can make it more likely that you'll be able to have a successful trial of void without requiring surgery. The main adverse effect is postural hypotension, and I warn all patients about that. Some patients also report just general levels of fatigue and dizziness. Floppy iris syndrome is something that is encountered during cataract surgery for all alpha blockers, as well as some of the phytogens that I'll mention later. So if there is any cataract surgery planned in the near future, it's probably best to avoid this class of drug and consider other alternatives. And the other thing that you have to warn all patients about is that they may have abnormal ejaculation, which has been now shown to be a result of reduced seminal fluid emission as a result of these medications. Now, this is reversible.
What does that mean, though, Praz? When abnormal, it's just as
there's less.
There's
There's less or none.
Right.
So for most men, it doesn't matter, especially if they've got family or kids. But a surprisingly large number of men find that ejaculation is an important part of their sexual health and sexual practices, and they really consider the loss of ejaculation as a major issue.
Right.
And so that has to be considered with this medication for that.
And that's different to retrograde ejaculation?
Retrograde ejaculation is related to, is what we see in TURP, where we resect the bladder neck. And so the tissues that normally close during, around the bladder neck during ejaculation to ensure that semen heads out through the urethra because it's lower pressure. Because that tissue is no longer there, the lowest pressure is actually back into the bladder.
Mm-hmm.
And so post-TURP, that's why you develop retrograde ejaculation, which is a slightly different phenomenon. I only realized that I only discovered this recently, actually, because previously I thought that they were the same phenomena for both for tamsulosin and for TURP, but apparently it's not.
Oh, thank you.
So the next class are the 5-alpha reductase inhibitors. So they block the conversion of testosterone to dihydrotestosterone, DHT, which is the active form in the prostate. And by blocking production of DHT, you induce apoptosis of prostate cells, and over time lead to a reduction in prostate volume up to 28%. That can take up to between 6 and 12 months to achieve that. The other thing we see with these tablets is that it'll decrease circulating PSA levels by about 50% in the absence of any malignancy driving that PSA up. So if you are monitoring the patient's PSA, you have a new baseline moving forward. And after 2 to 4 years of treatment, 5-ARIs, again, improve IPSS scores, Qmax. They're not as effective in smaller prostates, so prostates less than 40 cc's. They do reduce the risk of retention. They do reduce the risk of surgical intervention by a significant amount. Main adverse effects, though, are erectile dysfunction, reduced libido, gynecomastia in a small proportion, and of course, ejaculatory dysfunction. I try to avoid these patients in men in their 50s because I find that they report sexual side effects far more frequently than men in their 60s or 70s. But I do have some patients in their 50s who take this tablet and haven't reported any issues. Now, what you're probably more familiar with is the combination of a 5-alpha reductase inhibitor with an alpha blocker, and that's Duodart or doublets, which is tamsulosin plus dutasteride. Having the combination is superior to having each tablet on its own in terms of symptoms, in terms of Qmax, in terms of reducing the risk, the need for surgery or the risk of urinary retention. And there are multiple studies that show this. And this is the reason why Duodart is cheaper than getting tamsulosin on its own, because the combined treatment is subsidized by the government, because that's the one that shows the greatest benefit. The side effects are basically the sum of each individual component. In some men, instead of using dutasteride, I use 2 tablets, silodosin with dutasteride as Avodart. If they have significant postural hypertension, because sometimes silodosin is a better option for those men. And I've got a few men who are managed quite well on this combination rather than on Duodart. The next class are the muscarinic receptor antagonists. So this is oxybutynin, sulfenicin, darafenicin, the anticholinergics. You can use these as single agents in men with predominantly storage symptoms. And the benefit may be more in men with smaller prostates and with lower PSAs. They can increase the post-void residual volume, but as long as the PVR is less than 150 mils, the rate of acute retention is quite rare. The main adverse effects are dry mouth, constipation, stuffy nose, dizziness. These side effects are less with oxybutynin when delivered as oxytrol, so the transdermal patch. And that's because this avoids first-pass metabolism through the liver. It's that first-pass metabolism and those metabolites that cause all the anticholinergic side effects that bother men with Ditropan, for example, as a tablet, as opposed to the oxybutynin patch. The patch is now on PBS, so it's very cheap. It used to be very expensive until just a few years ago. So I routinely start with that if I'm going to add an anticholinergic. The main side effect, though, with the patch is a skin rash. So you have to counsel them on how to use it effectively. Don't put it on the same side each time. But even then, some patients can come off it because they do develop a rash over time. The next class is relatively new, the beta-3 agonists. This is mirabegron or Betmiga, comes in 25 and 50 milligrams. The mode of action is presumed to be through beta-3 adrenoceptor induced relaxation of detrusor muscle. So again, working on the bladder, but through a different mechanism. These have been shown to improve storage symptoms, including frequency, urgency, urge incontinence. And they're better tolerated than antimuscarinics, and patients tend to stay on them longer. The main adverse effect is hypertension. So in patients who have severe uncontrolled hypertension, they're contraindicated. They can cause other symptoms, UTIs, headaches, nasopharyngitis. There's actually quite a long list that comes with the medication, and a lot of patients just look at that and balk, and you have to talk them down and explain that they're all very rare. I've seen very few patients complain of anything on this medication and end up staying on it for quite some time because it works quite well.
Praz, the dose of 25 milligrams for the mirabegron,
yep,
or the 50.
So I may, if they're an elderly patient, I'll start on 25 and then work my way up. If they've got significant symptoms, or if they're a younger patient, you can start straight at the 50 and just see if there's any benefit. Another surprise, Betmiga works also particularly well for nighttime symptoms, and can reduce nocturia to a greater degree than the antimuscarinics. If you're trying to deal with nocturia that isn't responding to other medications.
Praz, I've got a question from Dilaruba. Can we initiate all these medications as a GP, or should they see a specialist review first? So I suppose I'm thinking of that Dublex or Duodart.
Yeah. So I've got a slide coming up once I go through all of them to just to have a basic rationale for starting these.
Thank you.
So you can combine the prostate and bladder medication. So you can use an alpha blocker with an anticholinergic, or you can use an alpha blocker with a beta agonist. And they do show benefits in terms of the storage symptoms and improving quality of life. It is relevant. It is important to measure post-void residual volume during treatment. Some of the side effects, for some reason, are more common when you combine the drugs, for example, dry mouth and ejaculation failure. But overall, this is a good combination of people who you've treated the voiding symptoms with the alpha blocker, but they still have ongoing storage symptoms. And there's some value in adding an agent that works predominantly on the bladder. Now, phosphodiesterase inhibitors. So Cialis is 5 milligrams is indicated for daily use. They can actually reduce IPSS storage and voiding symptoms. And there's, in terms of IPSS score and benefit, there's no actual difference between giving them Cialis or tadalafil versus giving them an alpha blocker like tamsulosin. The men who benefit the most tend to be younger men who are slimmer and who have more severe symptoms. And the other benefit is that it also improves erectile dysfunction. And I do have some patients who I manage purely with tadalafil. The contraindications are the contraindications for any man with these agents. So men who are using GTN sprays, who have cardiac disease, where the cardiologist is advised against sexual activity, if they've had recent heart attacks, they've got heart failure, arrhythmias, stroke within the last 6 months. And the main adverse effects are common flushing, headaches, gastroesophageal reflux, nasal congestion.
Question about that. Sorry, Praz. For the daily dose, is that erectile function on demand, or?
No, so the daily dose is 5. It's basically like, instead of taking tamsulosin 1 tablet daily, you're taking tadalafil 5 milligrams daily. Now, if you wanted to take a larger dose on the days when you're anticipating sexual activity, then you can take a 10 or a 20 on that day. For patients who have erectile dysfunction and lower urinary tract symptoms managed by an alpha blocker, they can interact with each other. So I warn patients to If they're anticipating using a phosphodiesterase inhibitor like tadalafil or Viagra or whatever else is their tablet of choice, that they omit their regular alpha blocker on that day. So don't take your tamsulosin on the day when you're planning to use one of these other drugs.
Can you combine the alpha blockers and the tadalafil?
No, that's contraindicated because they will drop their blood pressure, or they're far more likely to drop their blood pressure and experience postural effects. So there's no benefit in adding these two drugs.
Thank you.
Next is phytotherapy. So these are the herbal preparations that patients pay large amounts for from Chemist Warehouse, and they're preparations of roots, seeds, pollen, bark, and there are just some examples there. The only preparation that has evidence is saw palmetto, hexane extracted Serenoa repens. This can improve Qmax. It can have improvements similar to alpha blockers. There is a reduced risk of sexual dysfunction with these, but getting evidence is very hard because there's such a wide variety of products with different amounts of saw palmetto, different brands, different qualities. There is some evidence that you can use saw palmetto with an alpha blocker, and that actually results in a greater improvement in IPSS compared to monotherapy alone. I've never done that. The biggest side effect for these is gastrointestinal upset. They're pretty safe and easy to use. And oftentimes patients will come in and show you a bottle and say, "Oh, look, I'm taking this stuff. What do you think?" And it's like, "Yeah, sure." If it's working for them. So in answer to the question previously about medical management, what I would recommend is if you think that BPH is the cause of a man's lower urinary tract symptoms and that there are no red flags that would indicate referring the patient immediately, then start with an alpha blocker. Tamsulosin is probably the best one because very efficacious. It's been on the market for a long time. If they do have a history of postural hypotension, or if you're concerned that they're elderly and are at increased risk, then you can potentially start them on silodosin, because that also has the option of the lower dose to start with, which is the 4 milligrams, and then see how they go. A lot of patients who start alpha blockers have an initial few days of postural symptoms and then their body adapts. So, if they're not at risk of falls, and if it's a weekend and they're not, driving trucks or operating heavy machinery, it might be reasonable to give them that warning and see how they go. But in general, there are other options if they do develop those symptoms. So start with an alpha blocker. If they have a very large prostate, if they have moderate symptoms, if you think that are at a moderate risk of developing any of those complications we mentioned earlier, or if they're in an age group where it's reasonable to give them combination, you can add a 5-alpha reductase inhibitor, or go straight to take them off tamsulosin or avoid tamsulosin altogether and go straight to Duodart or doublets. If after being on that therapy they have refractory storage symptoms, then you could consider adding a muscarinic receptor blocker, an anticholinergic such as the oxytrol patch, Vesicare, darafenicin. If they have side effects with the alpha blockers, or if they have concurrent erectile dysfunction, you can consider using Cialis, tadalafil, as an alternative. Again, and also with the sexual dysfunction issues, you could also consider phytotherapy. So any of those, saw palmetto or any of those combinations as an alternative. And again, the times. Sorry.
There's a question. Does tamsulosin have an effect on cognition and memory, but not the silodosin?
It shouldn't, but sometimes when someone develops asthenia, dizziness, lower postural effects, that can affect cognition from that point of view. But it's not the same. It doesn't have the same effect on cognition as, say, commencing someone on androgen deprivation therapy, for example. So it's only in those patients who have postural side effects, really, where cognition may be affected. And it's really the postural hypotension is the feature. And silodosin, some reports are that it is better than tamsulosin. I find that that's not always true, but so that's why I always start with tamsulosin. It doesn't work, or if they develop side effects, then we try silodosin. Silodosin has its own. I find that they're more likely to have gastrointestinal side effects with silodosin than with tamsulosin, and that might, in fact, be increased diarrhea, nasal congestion. That may be the limiting factor in the use of those medications. So again, when to refer? You've started them on treatment for BPH, but they're still getting urinary tract infections. The ultrasound shows a high PVR or PVR that's rising. And by saying high, I mean greater than 100 to 150 mils. Or they've got bilateral hydronephrosis. You have to refer at that time, because the fact that the hydronephrosis is bilateral implies obstruction at the bladder outlet, which most likely will be BPH. Or could be one of the could be anything, but most likely BPH. If the ultrasound shows bladder stones, if there's any hematuria, if the patient has a high PSA or the PSA is rising and you're concerned about a concurrent cancer diagnosis, or complete failure of medical therapy, and in which case they would need to consider surgical options.
Prez, just a question: how long can these men stay on the medications?
They can stay on them for the rest of their lives. And some patients do. Some patients are completely against having any sort of surgical intervention for their BPH. So especially younger men. And so you can start them on tamsulosin, keep them on that for several years. Eventually their symptoms will progress. That's when you add the dutasteride, and then they can manage with the duodart dutasteride with the tamsulosin will reduce the risk of developing any complication that would require surgery. And so some patients stay on this forever. Some patients do develop progressive symptoms, or they develop complications despite being on maximal medical therapy. And they're the ones who need to go on to have some form of surgical intervention. But again, it's hard to predict who they will be and when that'll happen.
If you stop the medication, will the symptoms recur?
It depends on the medication. So if you stop the tamsulosin, yes. If so, stop the alpha blocker, yeah, the symptoms often do recur. If they've obtained significant benefit from it. Now, some patients can just be observed and their symptoms go away. And we don't know what caused their symptoms. We don't know why they've gone away. But, conservative management can work. And some patients want to try, and they will try taking themselves off the medication and see if it helps. Or if they can maintain their symptoms. In my experience, the patients who do come off medication eventually need to come on at a later stage. With dutasteride, because it has a long-term effect on reducing the volume of the prostate and actually causing structural changes, you can stop that medication and get away with not being on that for a longer period of time before symptoms recur. And again, the other agents, it just varies from patient to patient. You just have you can wean them off, try them off these medications and see if there's any benefit. Now, an example would be a patient with BPH causing both voiding and storage symptoms that you're managing with, for example, duodart and an anticholinergic like the oxytrol patch. Over time, as the bladder outlet obstruction resolves, the bladder itself does not have to work so hard against the fixed obstruction, and there will be structural changes in the bladder such that the sensation, the urgency won't be there, and you can potentially get away with weaning them off the oxytrol patch or whatever agent you have for their bladder. We see this more commonly after TURP, where all of a sudden we've done an operation and completely removed their obstruction, and the bladder is confused. It still thinks it needs to push as hard as it did when there was an obstruction there, and then the patient can have several weeks, if not months, of urgency. And in that situation, I would put them on an anticholinergic just to manage their symptoms for a few months, and then gradually wean them off and then have them on no medication at all. So yeah, different circumstances, you can wean patients off medication.
Great answer. Thanks.
So in terms of surgical management of BPH, there are so many different options, and they fit into broad categories. There's resection, which is a standard TURP or a bladder neck incision where you're cutting tissue away. Enucleation, where you're basically scooping out the transition zone that is enlarged, and that's either an open or robotic simple prostatectomy, or HOLEP, which is a laser procedure that does the same. And I'll be describing all of these in detail. All of these are available in Melbourne. Vaporization, which we commonly use the green light laser for that, is another option. There are these new alternative ablative techniques, including aquablation, prostate artery embolization, and Resume, which I'm sure a lot of you will have patients coming and asking, oh, I want Resume, and then you send them off to have Resume. I'll explain that in a minute. And then there are non-ablative techniques, including UroLift. So TURP, this is the gold standard surgical procedure. We've been doing this for 150 years, if not longer. It involves, under an anesthetic, either spinal or general, passing a telescope down the urethra to the level of the prostate, and then through that using a resection loop through which electricity passes to scoop away at the prostate from the inside. And you can see from this picture an enlarged prostate, and then we scoop a channel for the urine to pass through. There are substantial improvements in flow, in symptom score, in quality, improvements in quality of life, reduction in PVR, and the need to repeat this operation is about 1 to 2% per year. I'm going to say something slightly controversial. Some practitioners tell their patients that the need for repeat surgery is after about 5 years. It's closer to 10 to 15, and I tell all of my patients that. And there are obvious incentives for having that approach to this operation. But not just international data, but Australian data is that the redo rate should only be about 1 to 2% per year. Now, in terms of complications, about a 3% need for a blood transfusion. TUR syndrome, which I'll discuss shortly, is very rare these days. Some patients go into retention after the operation just from swelling as a result of the resection, and may require a catheter for about a week, but they often pass the trial of void after that. About 5% of patients experience erectile dysfunction, but more commonly and pretty much universally, they'll develop retrograde ejaculation, as we discussed shortly. And there's a small risk of bladder neck contracture or urethral stricture. Bladder neck contracture tends to be more common in patients with smaller prostates who have had excessive bleeding requiring excessive diathermy for whatever reason. And urethral stricture tends to be in patients who have had any sort of traumatic history or trauma to the urethra that is exacerbated by the procedure.
How do you, Paz, how do you test the PSA then once they've had a TURP?
Oh, you just see what it is, and that's your new baseline. So you check it before as part of your workup to make sure you're not missing prostate cancer, because although you can do a radical prostatectomy after doing a TURP, it's a lot harder. And you deal with the bladder outlet obstruction and their prostate cancer at the same time by taking their whole prostate out. So, and again, that's nuanced based on comorbidities and age and patient preference. But
okay,
after they have the TURP, the PSA will drop significantly, and then you just keep watching it from that new baseline.
just asking about retrograde ejaculation again. I don't quite understand it. So how does a man feel? Was it reduced volume again, or was it a different thing?
So the sensation of orgasm doesn't change, but what does change is that there is no emission. So instead what happens is that it goes backwards into the bladder, and the next time they go to the toilet to pass urine, it comes out as cloudy urine.
Thank you.
So standard TURP involves electricity passing through the instrument, through the patient's body to a pad on their thigh, for example, creating the electrical circuit. A bipolar TURP is a device where the current passes through the instrument alone. So it doesn't pass through the patient's body, it just passes through the instrument. And the main benefit of that is that it allows isotonic saline to be used as irrigating fluid rather than hypertonic glycine. This is much safer, and it allows us to operate on much larger prostates. And the reason for that is that we can avoid something called TERP syndrome. Before we had bipolar technology, we were limited on using a TERP for prostates up to 100 cc's if you're good, smaller if you're in training. And that was because we would irrigate with glycine. Glycine, if you operate for too long, can be absorbed by the body through the venous sinuses. That can cause the sodium to drop, and the patient could end up with in ICU, acute renal failure, confusions, coma, pulmonary edema, convulsions, in worst case scenario. With a bipolar TERP, because the current isn't passing through the patient's body, you don't need to use glycine. You can use saline, and then there's no TUS. There's no TERP syndrome. You can operate for as long as you are comfortable. You can operate on really large prostates if you have the stamina, and there's no risk to the patient. Simple prostatectomy with bipolar TERP, it's available very widely. It tends to be more of a south of the Yarra thing from a training point of view. Certain hospitals, people going through those public hospitals have trained on bipolar machines and are very comfortable with it. St. Vincent's, the Alfred, for example, Monash. Other hospitals prefer the monopolar device. And it just comes down to preference. I routinely will do a bipolar TERP. I find that it's got far superior hemostasis, and I don't have any stress about the size of the prostate or how long I need to operate. I think it's a superior device. At the moment, the current device that you see there, the Gyrus, has that company that made the original bipolar device was bought by Olympus, and then Olympus decided to kibosh this device and have produced their own device, which is terrible and has terrible hemostasis. So I do all my bipolar TERPs at Cabrini now because they have a new device that's a French manufacturer that works really well. So it's everything changes. Technology is important. Finding the right equipment is important. Simple prostatectomy. So this is traditionally for glands larger than 100 grams in the monopolar era. And basically what would happen is either through the bladder or via the prostate capsule, basically stick your finger in there and scoop the prostate out. The major comparison is with a new technique called HOLEP, which I'll mention shortly. There's no difference in terms of quality of life, reoperation rates, IPSS score. It is a shorter operation than doing a HOLEP, but there is increased blood loss, length of stay in hospital because it's an open operation and catheter time. Ideally, you wouldn't make an incision this big for this operation, but it's good for illustrative purposes. Some people are starting to do robotic simple prostatectomies. I've done all of mine open. I've been very comfortable doing them open, but I probably will. I haven't felt the need to use a robotic approach because I'm very comfortable using the bipolar device and just doing the whole thing endoscopically rather than putting a patient through a much more invasive operation for this. Now, HOLEP. Now, this is holmium laser enucleation of the prostate. Very similar to TERP in terms of short-term efficacy. The diagram shows basically a laser. You're basically peeling an orange from the inside. The orange pulpy bit being the adenoma, and that's also illustrated in the lower image. This can take a lot longer than an open prostatectomy, for example, or a TERP, but the blood loss is less. There are need for fewer blood transfusions. There's no difference in terms of stress incontinence rates or urethral strictures, erectile dysfunction, or ejaculatory dysfunction. It can be performed safely in anticoagulated patients, which is a major benefit. There is a learning curve associated with it. There are a handful of practitioners who perform this technique in Melbourne. I don't use it because, again, I find the bipolar is sufficient. The thing, once they've nucleated the adenoma, in this technique, they put in a device called a morcellator, which basically grinds up the adenoma and sucks it out. So that's how they get it out through this technique. A more common technique with the laser used in Melbourne is the green light. this is either KTP or LBO. Most people use KTP, green light. It's, as described, a green light, and so everyone's wearing goggles to protect their eyes, and the theater is essentially illuminated by this green laser. Compared with TURP, at 2 years, there's no difference in terms of the functional and symptomatic parameters. They have shorter length of stay, they have shorter catheterization time, there's less need for blood transfusions, there's less clot retention. There is a significantly higher reoperation rate with the laser within 3 years. There is a lot of people who push for the green light as a good option, say that is superior in patients who are anticoagulated, but there's very little evidence that shows this. And there are higher rates of bladder irrigation, delayed gross hematuria, high-grade complications in patients in whom anticoagulation is continued and they have a green light procedure. Anecdotally, these patients have prolonged dysuria after the operation and urgency, and require, out to 3-4 months and require more support in that setting. I don't perform green light again because I think the bipolar is an excellent option, and I don't see any benefit necessarily to using this device. Now, in terms of newer treatments, aquablation. Now, this involves using high velocity saline to ablate prostate tissue in real time using an ultrasound. So in the image, you can see an ultrasound probe in the rectum, and in this diagram, you see the area of the prostate that's being affected by the steam treatment. Once they've done the steam treatment, you then have to achieve hemostasis. How to achieve that at this stage hasn't been fully confirmed, but some people keep a catheter on traction. They use diathermy. Some people use a low-powered laser. Compared to TURP, there's no difference. It can be used for larger prostates, but there is a higher rate of blood transfusion return to theater. There is limited availability of this in Melbourne. At this point in time, I'm only aware of this used in the trial setting at the Royal Melbourne Hospital. I'm potentially incorrect about that, but as far as I'm aware, that's the only place where I've heard that this is in use. But it's an emerging technology. Convective water vapor ablation is Resume, which a lot of you have probably heard about from your patients bringing wonderful marketing material to you and about it. Basically, this involves using radio frequency and thermal energy to create water vapor, which then is like basically steaming the prostate. So as you can see in the picture, a needle goes into the gland, it steams an area, and then that tissue undergoes apoptosis, dies. And apoptosis and necrosis dies. So again, very early days with this technique. There's about a 4% surgical retreatment after 4 years. There are no RCTs. There are no comparisons to TURP. Practitioners who do this in Australia have reported needing their patients needing a catheter at home for a week afterwards, as well routinely, as well as antibiotics during that time to prevent infections. Some people say it's an excellent option. My neighbor had this, and he thought it was great, but he didn't really have anything to compare it to. There is limited availability again in Melbourne. I'm only aware of Mulgrave Private Hospital purchasing the equipment for this. I think most other urologists are adopting a wait and see approach with this particular technology. Prostate artery embolization, I've been going on for some time. I'll finish soon. Day procedure under local anesthesia, requires specialized training a radiologist with specialized training. It takes a long time to do, although there's improved blood loss and length of stay and catheterization. It's not as good as doing a TURP. It's probably best suited for those patients who are not suitable for an anesthetic. Very elderly patients in retention who are on anticoagulation are probably the best candidate. Large proportion of patients do require a TURP after 2 years. And finally, UroLift. In this technique, the UroLift device is used endoscopically to place these little implants, these sutures, that compress the prostate and thereby relieving obstruction. Benefits: there's no cutting, there's no heating, there's no removal of prostate tissue. It can be done under a local anesthetic, although I've only done this under general. It can be a day case without a catheter. And importantly, it does actually preserve ejaculatory function. It's not as effective as a TURP, although quality of life has been similar. If a patient has an enlarged median lobe, you cannot effectively treat it. There is one practitioner in Melbourne who has combined Urolift with green light laser prostatectomy to just basically use green light on the median lobe and Urolift on the lateral lobes. And seems to work well. There is a high reintervention rate. I've had a couple of patients who I've placed the Urolift anchors in, and they've lasted maybe 2 or 3 years, and then they started getting indications for surgery in the form of recurrent infections or worsening lower urinary tract symptoms. I find that when you go in afterwards to do the subsequent TURP, they have dysuria and urgency that can last several months before they finally settle down. And as a result, I've sort of lost, I wouldn't say I've lost interest, but I have reduced interest in this as a treatment option for most men, but that's just my preference. So take home point number 6, there are many ways to skin a cat, as you can see, a lot of different ways we can treat the prostate. But just because something is new doesn't make it better. There is a graveyard of failed techniques, and some of the things I've just mentioned will probably end up in this graveyard as well. And we'll all go back to doing a TURP anyway. So going back to our learning outcomes, number 1, with regards to the initial assessment, it's always good to have a renal tract ultrasound, do a urinalysis, PSA, check their kidney function, and major red flags. Medical therapy doesn't work, they get any of the complications of BPH listed, or if you're concerned about malignancy. And that's my presentation. Any questions?
You've answered so many as you went along. It was fantastic, Prez. Thank you.
Thank you. Thank you so much, Prez. That was fantastic. You covered an awful lot in there. So we are running a little bit over, but if you don't mind everyone just staying on while Georgia presents as well, it'll probably just be an extra 15 minutes or so. That would be great. So thanks so much again, Prez. And do you mind just stop sharing your screen there, and then Georgia will, yeah, she started. Fantastic. Thank you.
All right, so my screen's come up fine there, Grace?
Yeah.
Cool. All right, so thanks everyone for sticking on, and obviously thanks so much, Prez. That was a really wonderful talk and detail there. So with the physio management for LUTS, we're really looking to the conservative therapy, which Prez did touch on to there, but we'll go into in a little bit more detail. Really looking to a GP situation of how many people have incontinence. So these are just from the most recent continence report. If we go down to men, it's of looking to that urge incontinence with prostate disease, so the BPH. It increases to sort of up to over 50% in men 85 or older. The continence mechanism in healthy males, so these are the requirements for continence and control and good emptying as well, that we need a bladder that can fill up and stretch appropriately, that the pressure inside of the urethra needs to be higher than that of the bladder in order to prevent urinary leakage, and that we need a really good coordinated contraction of the detrusor with a relaxation of the internal urethral sphincter and the skeletal muscles in order to have good flow and good emptying. And also there that the pressures equalize in the bladder and the urethra at almost empty, so that you're not getting that significant post-void residual. This diagram from here is just a really nice picture that we show to all of our patients in describing continence, but it's part of a full video for prostatectomies that's available on our website. As pelvic floor physios, of course, the muscles are our focus. So to know the pelvic floor function in and around the urethra, we're looking to the pelvic floor, the puborectalis and bulbocavernosus, and also the striated urethral sphincter, which has been demonstrated more recently to play a large role in urinary continence in men. The obviously important parts to having bladder control is through the neural system as well. And what we're looking to from here is the sort of parasympathetic and sympathetic nervous system for bladder control, as well as the somatic, so it's the pelvic floor muscle contractions, and the processing of all that information in the pontine nutrition center and how far then that goes up to the cerebral cortex. So as Praz mentioned, the symptoms of LUTS fall into those two categories of troubles storing or troubles emptying, and we talk to the idea of urgency and frequency with or without incontinence, and nocturia as our storage problems, and then the slow void, slow post-void dribble, which can in themselves with incomplete emptying lead to urinary frequency. Whilst the majority of the men that we see as pelvic floor physios are the pre and post prostatectomy men, we are seeing more men for urinary urgency and frequency and voiding dysfunction, as well as pelvic pain and erectile dysfunction, as the evidence grows and the knowledge that you can refer to physio for these problems spreads. So really where we're looking to for the clinical assessment as a guidelines from the ICI is that pelvic floor physios can do a majority of these things, and I'll go through the parts that we spend the time doing with a referral from a GP or urologist. So the bladder diary and outcome measures and quality of life and desire for treatment are the two areas we discuss in detail with patients. The bladder diary, as Praz talked to, is really great for that information. It can give us the polynocturia index, the amount of times that they're voiding overnight and in the day, what is their normal versus what we would consider normal, as well as to look at the basics of fluid intake and any patterns that we're seeing around their caffeine or alcohol intake, and then their urinary symptoms. One way that we simply use Excel to generate a lot of that information is to put all our volumes into Excel, and it comes through with the average voided volume, our polynocturia index, and we can also then plot that to a graph, and where it should really be linear, the urge rating to volume, but on a dysfunctional bladder you might see lots of high urges, so level 4s at the end there at low volume, and that's where we look to those detrusor, overactivity or instability. The IPS is a questionnaire Praz mentioned in from there, as well as the TANGOS. This is a nocturia questionnaire, which just really helps to piece the cause of nocturia a little bit better. So it breaks it into general well-being, urinary tract symptoms, sleep symptoms, and any cardio or metabolic symptoms as well. And the other that I mentioned there, we use less frequently, but for those, the bother is just sort of how much these symptoms are bothering somebody out of 10, so the VAS style scale, and then a Padway diary if someone is actually incontinent with their LUT symptoms. One other thing is pelvic floor physios, if you've got access to an ultrasound or bladder scan, is to perform the post-void residual, and we can also do a dipstick urinalysis and refer back to the GP for further testing if it's a suspect of a UTI. And then, of course, assessing pelvic floor function. So for men, we're really looking to assess for pelvic floor muscle strength and tone. And I think this is where sometimes the idea of pelvic floor physio that muscles are always weak is not necessarily the case. So we look to testing for weakness or strength, but as well as tone. So that's the resting position of the muscle. Is it normal tone or high tone? And then what happens during voiding, or as when we're assessing, it's either they would have a flow in rooms at somewhere like APC with us, or looking at attempted simulated either defecation or voiding. So what will this patient do? And they say they're straining to empty. Pelvic floor muscle assessment for men has come a long way with the use of transperineal ultrasound. So Paul Hodges and colleagues up in Queensland have researched the male continence mechanism and the striated urethral sphincter in great detail. And we're now looking that this is our gold standard of assessment. And the transperineal ultrasound can be used by the qualified physios to really look at muscle function. It's also great for patient biofeedback and functional integration. And what we mean by that is just putting pelvic floor exercise into the moments and times where people leak to make their exercise appropriate and beneficial. So most of within that treatment pathway, other than prescription of medication, pelvic floor physios can address a lot of these things. And we also have the time to. A lot of the time I think that we spend with patients is in and around motivation and coaching and long discussion. How long I talk to people about caffeine intake, it's quite remarkable. But then we also obviously go through into the lifestyle interventions, pelvic floor training. So if we work through the main areas, so overactive bladder, nocturia, and voiding dysfunction, our main goals of overactive bladder patients are to improve the capacity. So that's the compliance or stretch of the bladder so that we can improve the time between voids. And we want to reduce the inappropriate messages from the bladder. So that's looking to a bladder diary where someone has a good emptying, so low post-void residual, but then they're passing voids urine of 100 to 120 mils, but with an urge rating of 4. We want to control that and improve the suppression of urge. So that's the control down from the brain to the bladder. And that can be helped with improved pelvic floor function and obviously addressing contributing factors. Bladder training is a big part of what we do with patients. I often thinking it should really be called brain training, but we look to the local strategies. So in and around the bladder, we're looking at what can override the parasympathetic stimulation. So the idea of a pelvic floor contraction, so a good contraction can inhibit the bladder contraction, as well as perineal pressure, again, is an inhibitory reflex. And we look at pathway strategies. So for the lower lumbar sacral area where the supply from the bladder comes into the spine, we can stimulate other areas that come into that area of the spine. So that's where toe curling, calf rubbing, heel toe walking all come into a distraction from the message from the bladder. And TTNS, or transtibial nerve stimulation, is really a newer area that's demonstrating to have some good evidence behind it. So you may very well have heard of PTNS, or percutaneous nerve stimulation, and TTNS is the same, just with a TENS machine. So the image up there on the right shows those sticky pads that go over the tibial nerve supply. And this systematic review just demonstrated that it could be a promising first line of management for people with OAB, in particular those that may have adverse response to medications and surgeries. So it's looking to the more elderly or neurogenic bladder population. It's very cost effective. A TENS machine will set you back $60 or so. And Aldi often has their special $35 once a year, but it's very easy for patient setup, it's cost effective, and it's low risk. The idea being is it stimulates nerve root fibers at L5 to S3. It's got a very low frequency input, so it's not going to get a muscle contraction, and you placing it over that area for 30 to 60 minutes. So far, treatment frequency is not set in stone, so once a week to daily for up to 12 weeks. And the main outcome measure we use is the ICIQ OAB.
Georgia, for the TTNS, after a 12-week course, is it long-term resolution of symptoms, or they need to repeat it in a year's time, or what's the
My understanding from it is that the effect can last, that has good efficacy for up to 12 months. Often it's similar to PTNS, and they do a weaning process of it. So instead of going 12 weeks and then they stop, they might go down to once a week, or for maybe 2 months, and then once a fortnight, once a month, whatever's tolerated by the patient.
Right. Like a low maintenance.
Low maintenance. And generally, because it's so non-invasive. And if patients have had a good effect, they're very willing to just keep using it.
Yeah, thank you.
Yeah. So then, our central strategies, and this is where we really are looking to calming the nervous system. And I can just do that in my own breath now after feeling like I'm rushing through. You know, we pause, you take a breath, and we're looking to how we might calm down the nervous system in order to not sort of catastrophize the urgency. If people are incontinent, that's a very much harder thing to do. But in doing that, we can be allowing the bladder to stretch and fill and are calming down to then focus in on our other distraction techniques. Changing environment is often a very useful thing because we're addressing what's actually triggered that urgency. So you'll know of key in the door, as well as people once they've decided they're going to the toilet. Once they've thought of that, they can't, bypass or go and do anything else. So addressing the trigger and desensitizing to that is a common thing we work on. Otherwise, down to the lifestyle and education, really we're looking to some people, we actually just look to scheduled void. So if they're having a lot of these level 4 urges that are very inappropriate to how much is in there, they will take the time between the urges and just taper it off a little bit, and look to kind of nudge out against their urge ability over that time frame, rather than asking them to suppress something that's very difficult to suppress. And that's where medication is often helpful to use in an adjunct as well. Lifestyle interventions, Praz spoke to this concept of all the contributing factors. So we're looking to general exercise, weight management, fluid intake, and an understanding of what good bladder habits are, and expectations to a bladder, whether it be a 35-year-old bladder or an 85-year-old bladder, as part of that.
Just a question.
Yep.
Going back to the previous slide, Rob was asking, is there any benefit from meditation for brain training? Yes.
Yeah. Well, if you think to the purpose of meditation, then if it's affecting your nervous system to be in a more calm and relaxed state, then it can certainly be something that's worth doing. Generally, things along the lines of meditation are very personal as the uptake of them. And I think you'd put it around to a skilled meditator is more likely to be able to use those skills within the moment of urge, but could be very useful to do as a adjunct outside of urgency.
So you might need to practice it. Yeah, you need to practice it when you're not urging. And then when you do have the urge, you can then tap into it.
Exactly. Yeah. Like most things, it's like you can't expect to be skilled in doing something in the moment of panic. You need to be good at doing it, practice when it's not, under pressure.
Thank you.
All right. So obviously then pelvic floor physio, pelvic floor muscle function. So the timing of a contraction and tone, I think sometimes we, as again, it's not just about strength and can you hold. So the ultrasound's really helpful into this, that patients can see what's going on. We can see the amount of closure that somebody is getting, but also the ability to relax for the voiding dysfunction that we'll come to. Often at this point, I think we get a few questions. Well, there's a brochure. Why can't I just hand that out rather than referring on to physio? But there is some research. It was done on physio students for pelvic floor contractions, and about a third of people are doing it correctly. A third just don't quite get it right, and another third could actually be doing enough to be counterproductive. So that's a lot of straining and pressure from the abdominals. The other thing was I did a quick Google search for pelvic floor exercise for men, and one very reputable one came up, so the Continence Foundation handout. But then if you look to this one, Kegel exercise for males, it's demonstrating a bridge, which is a contraction of the glutes, the hamstrings and the back muscles, maybe some pelvic floor. But if we think to that as being what some people come in and say they're doing pelvic floor exercise and that's what they're doing, we can see that that's not really appropriate to continence control. So obviously, as a pelvic floor physio, I'm going to promote this really strongly, but the concept to the benefit of assessment, personalized exercise prescription, as well as a lot of discussion in around patient buy-in, so motivational interviewing, but also looking to the person and not just the problem within the goal setting and realistic expectations, but also realistic training parameters for people. 3 sets of 10-second holds 3 times a day is not going to be effective for everybody. So knowing what's realistic is important. And then the last parts for OAB, we're looking to addressing bowels. That's really important from a constipation can really exacerbate OAB symptoms, as well as some other adjunctive therapies I won't go into today. Nocturia, I think there's something that can be worked on, multidisciplinary approach, of course, in that GPs have a much better understanding in and around underlying health conditions and medication. But within physio, we often talk to voiding advice, as Praz alluded to, the fluid management, edema management. So if someone's taking on or storing a lot of fluid over the day and then at night it's being reabsorbed, then we're often looking to when we get that increase in output overnight and people's sleep hygiene and general exercise. Voiding dysfunction, again, I think is something that people don't think to physio initially. Where we look to our assistance is in that post-micturition dribble, as well as the slow flow as well. We're really looking to the cause of it, where we've got things as Praz mentioned, the BPH or BPO or a stricture, as well as potentially pelvic floor dysfunction or neurosensory dysregulation. The principle of the pelvic floor dysfunction is that if someone has a large prostate and their bladder is working hard to put pressure in over the top, that then the person feels like they need to apply pressure. So they increase their abdominal effort, but in doing so, they actually increase their pelvic floor muscle effort. So they have a contraction around the urethra whilst they're trying to pass urine through their urethra. So in order to assist these people, we look to relaxed voiding, where really we're looking to say the bladder is doing its best job, and we're trying to get the stomach muscles out of the way to get the pelvic floor out of the way. We're also looking to voiding techniques like revoid or posture for gents, whether that be if they're standing, should they try sitting, or if they're standing, can they take the effort out by sort of leaning forward, so hand on the wall, or alternating between different postures. We also look to general body relaxation, which is where that meditation might come up, or relaxation techniques during voids as well. Big things to consider outside that we're always talking through with patients with any urinary symptoms is bowel dysfunction, erectile dysfunction, pelvic pain, their general exercise and diet, and talking to weight management, where higher weight has an increased risk of voiding dysfunction, urinary incontinence, and overactive bladder. I did have a couple of case studies to talk to, but I think I might leave those for this evening. If anyone would like to see them, you can email me after. But the important part from any gent with LUTS is to look to the potential they might benefit from some containment in the time they were working on treatment. So generally in LUTS, it's a pad usage. So those who are having a larger post-micturition dribble, or those with urge incontinence. The CAPS funding can be something to consider for the cost of covering those. But overall, we looked at pelvic floor physio can be an effective conservative treatment. It's low risk and it's low cost, and referral would need to be, though, to a physio with postgrad qualifications in continence and pelvic floor. And the next slide will show where you can find us. It can be used in conjunction with medications, and it's looking to the adjunctive therapy like TTNS can be helpful in urgency. And the biggest part is just expecting correspondence and an open dialogue around treatment for the importance of the multidisciplinary approach. We'll often see patients and then refer back with a suggestion to the benefit they might have from seeing a dietitian or an exercise physiologist, or for further medical investigation if they haven't had that already. So pelvic floor physios are unique in they've got a postgrad qualification, and those that have and are registered can be found on the CFA Physios Victoria group, and that's that website there. The APA, or the Australian Physio Association, also has a Find a Physio tab, and you can check to see if they have the qualifications. And if you can't have access to those, just making sure that people have either the titled continence, women's health or pelvic health physiotherapist, or that postgrad qualifications. As far as referring to physio, I'm sure most of or all of you are aware to the idea of the chronic disease management plan, where we're looking that with a referral from the GP, there are 5 Medicare funded visits that can be allocated to physiotherapy over a calendar year at non-for-profit places such as the APC. That's minimal out-of-pocket cost to that, now that that Medicare amount has gone up to $58. The private practice physio, there will be a gap fee, and in public hospitals and services, there's no fee because it's on the public system, but the wait list for clinics can be quite long, and often it's a referral is required. So that is a reasonably rushed, so hopefully not too fast, explanation of physio in the male LUTS population. If anyone has any questions, feel free.
Thank you so much, George. That was absolutely fantastic. And thank you everyone for staying on, because we did go a bit over time, but the information was really so many pearls in those 2 presentations. So thank you.
Yeah, thank you, Braz and Georgia, and some brilliant take-home points for all the attendees tonight. So thank you so much for your time, as always, in presenting tonight, and Jane for moderating as well. And we will be sending out a link to the recording of this evening's session as well. And just a reminder to complete the evaluation that will appear on your screen as you leave the session tonight. So keep an eye on the website for upcoming sessions that we'll be holding, and you'll be able to register online when things are open for registration. So thanks again to our audience, and of course to our speakers. Thank you and good night.